Hey everyone, we're back with another heart. You'll see that this specimen has the airways and the lungs still on block, and that the orientation is a little different than we usually start off with. But you'll see that in fact, here is the trachea up here. So superior head is up here. Inferior legs are towards the turntable. Anterior is coming out this way. Posterior is in the back over here, left over here, right over here. So this is kind of like as if the person were standing up right in front of us, and it's kind of happenstance and that this structure is kind of falling down and coming into better view for us because we are actually going to start off there. Although we generally start off with what we think is externally the morphologic right atrial appendage, which this is it. Triangular, broad-based, or pyramidal. This heart is unique in that we do see a very prominent brachiocephalic vein that drains into the superior caval vein. And we can see without much effort that in fact the pulmonary veins drain into a confluence that then drains into the brachiocephalic vein that then drains into the superior caval vein. So here is the left lung. We can see left pulmonary veins. Here's the left lung. We can see left pulmonary veins that drain into a confluence here. And then this confluence drains into the brachiocephalic vein, which then courses back, drains into the superior caval vein, which then drains into the right-sided atrium. Now, when we look at the left-sided veins, and we'll just flip the heart over, we see that the left-sided pulmonary veins also drain into this confluence, and then here are the right-sided pulmonary veins coming in, which then drain into that brachiocephalic vein, which then drains into the superior caval vein here, and then the right atrium here. So we are dealing with supracardiac, total anomalous pulmonary venous connection. Once again, here's the pulmonary venous confluence, here's the brachiocephalic vein where it drains into, then here is the superior caval vein, which then drains into the right-sided atrium. But now we can go ahead and kind of go back to what we usually do, which is find the, at least morphologically, externally, what appears to be the right atrial appendage, and here that is, broad-based, triangular, or pyramidal in shape. And when we open it up, we immediately find that there are pectinate muscles that spill outside the confines of the appendage. But we also notice very quickly that there is a very prominent eustachian valve here that actually divides the right-sided atrium nearly into two components. We've seen the superior caval vein drain up here to the roof of the right atrium. And then we also see that the inferior caval vein is actually retained and drains right behind the eustachian valve here. And that, in fact, its return, as well as the oval fossa, live behind this eustachian valve. And so here is the oval fossa in the back here. And you can see that there is an oval fossa atrial septal defect, and that this eustachian valve does divide this right atrium into two distinct chambers, although there is a sizable orifice here. So there's this posterior chamber here that accepts the inferior caval vein and also contains the oval fossa and the oval fossa ASD. And then there's this more anterior chamber which contains the rest of the right atrium. So a divided right atrium due to a prominent eustachian valve. Here is the mouth of the coronary sinus. Here is the tendon of Totaro. And so whenever we have the mouth of the coronary sinus and the tendon of Totaro, we must think about the triangle of Koch. And its third border is, in fact, the right-sided AV valve. So the triangle of Koch would be roughly here, and at its apex is where we would expect the atrioventricular node to live. When we look at this right-sided atrioventricular junction, we do find that it's guarded by a 3-leaflet atrioventricular valve that has direct connections to the ventricular septum, consistent with the morphologic tricuspid valve. Note that this atrioventricular valve does have a round or oval-shaped annulus. The ventricle it opens up into has coarse trabeculations, and here is the septomarginal trabeculation, all consistent with the morphologic right ventricle. When we get into the right ventricular outflow tract, we find a semilunar or arterial valve here that's entirely supported by muscle. As always, take note that the arterial valve does not have an oval or round-shaped annulus. It's actually crown-shaped, as the fibrous valvar leaflets have myocardial triangles interposed, so these interleaflet triangles. That does not mean that the round or oval-shaped annulus that we create to help with clinical decision-making isn't helpful. It's just to say that the arterial valves have a naturally crown-shaped annulus. So here's the 3-leaflet, 3-sinus pulmonary valve. Here's the pulmonary trunk. Now, if we flip this heart over, here's the left atrial appendage. And now we open up another atrium here that's smooth-walled. All of the pectinate muscles are confined within the appendage itself, consistent with the morphologic left atrium. Here is the atrial septal defect from the left side. And here you can see that the left-sided atrioventricular junction is guarded by a 2-leaflet atrioventricular valve that does not have direct connections to the ventricular septum, consistent with the morphologic mitral valve. This ventricle here has fine trabeculations, consistent with the morphologic left ventricle. And the LV outflow tract isn't really dissected open here, but there is a normal left ventricular outflow tract. So once again, to highlight the pertinent features of this heart, here is a pulmonary venous confluence that drains into the brachiocephalic vein, which then courses and drains into the superior caval vein, which then drains into the right atrium. So, supracardiac total anomalous pulmonary venous connection. Then in the right atrium, there's a very prominent eustachian valve, which divides the right atrium into 2 components, a posterior component, which actually accepts the inferior caval vein and contains the oval fossa, and there is an oval fossa atrial septal defect, and then a more anterior component that accepts the superior caval vein as well as the mouth of the coronary sinus. So, supracardiac total anomalous pulmonary venous connection as well as a divided right atrium.